Good afternoon, everyone. My name is Laura Aird, and I work for the EIIC EMSC Innovation and Improvement Center, and I'd like to welcome you to today's fireside chat on suicide screening. Next slide, please. HRSA funds not only the EMS for Children Innovation and Improvement Center, this collaborative, but also this event. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. Next, please. Thank you for joining. You all know that this is part of the ED Stop Suicide QI collaborative. Please remain on mute for the presentation. The fireside chat is being recorded and it will be posted online along with the slides. The web pages were recently updated, so you will be able to see past recordings and then the links to all the future fireside chats as well as the collaborative sessions. You do need to register individually for each one, and then you get a confirmation and you can modify that quite easily into an appointment. Thank you for doing that. Please do put questions in the chat. We're interested in what you're thinking and wondering about. And we will have discussion and Q&A that will follow the presentations. Next. I'd like to turn it over to Dr. Jen Hoffman.
Hi, everyone. I'll be helping facilitate the session today. So the focus of this fireside chat is on suicide screening, and the suggested aim or goal for sites is for 100% of sites to have a process or guideline that relates to universal suicide screening of children over 10 years of age using a validated screening tool. And you can see an example of such a guideline on the right. Next slide. There are also associated quality measures that have been suggested to go along with the suicide screening bundle. These are optional if your site chooses to focus on this aspect of suicide prevention. Measure 1 is the presence of a mental health clinical care process or guideline that utilizes a validated screening tool for suicide and recommends universal screening for all children over 10 years of age. Measure 2 is an outcome measure, the percentage of physicians and nurse staff who demonstrate high-level knowledge in using a validated screening tool to assess for suicide risk in the pediatric population. And then measure 3 is a stretch goal, a process goal, which is to measure over time the percentage of pediatric patients over 10 years of age with documentation of suicide screening. Next slide. So I'd like to introduce today's two speakers. We're very fortunate to have Dr. Jackie Grupp-Phelan. She's a professor and vice chair in the UCSF Department of Emergency Medicine in the UCSF School of Medicine and chief of pediatric emergency medicine at Benioff Children's Hospitals. She conducts mental health services research with a particular focus on suicide screening. And she's received multiple large federal grants for this type of research, including a UO1 study that included 13 ED sites, a K23, and a CDC R01. She's also the lead of the PCARN Mental Health Work Group. Also today, we have Angela Nguyen. She's clinical pediatric social work manager at Dell Medical School at the University of Texas at Austin. She's also an assistant professor of practice at the Steve Hicks School of Social Work. She completed her training at Boston College and Boston Children's Hospital, and she has a wealth of experience in integrating mental health and suicide screening into hospital-based programs with a specific focus on pediatric medical settings and emergency services. We're very fortunate to have these two experts today, and I'll turn it over to Dr. Grupp-Phelan.
Hi, everyone. Good afternoon. I hope that you find this useful. Our goal today is to discuss some of the major issues related to suicide screening and hope to have at least 20 to 25 minutes to open it up to discussion so that we could spend some time answering the questions that you all have in terms of trying to implement screening in your settings. So today's objectives are to identify key considerations in conducting suicide screening. We want to talk about the importance of and the process for universal screening. We'll discuss some validated tools and where to find those on the EIIC webpage. And we will review important issues related to how we conduct screening. And finally, we'll talk about how are some different approaches to talking to children and adolescents and even parents about suicide screening. And then finally, we will set up the next fireside chat, which is going to be related to risk assessment. Next slide. So I'll spend a little bit of time talking about the epidemiology of suicide screening and some issues related to screening for suicidality in the emergency department setting. And then Angela will take over to discuss some of the operational challenges and important things to think about as you implement screening in your setting. So one of the really important questions that we get from parents frequently and from our team members is the worry that if you ask about suicidality in these young adolescents, that there is a worry that we might start to introduce thoughts of suicidality by just asking the questions. And we actually have had a good bit of evidence to support that suicide screening is safe. It does not increase distress or depressive symptoms in or suicidal ideation in kids once we ask these questions. And in fact, we know that it's really important to ask these questions in this population because suicidal kids tend not to seek care. And so we really want to take advantage of every setting to ask these questions. They aren't going to their primary care offices, and often the emergency department is the one place where they might come. Next slide, please. One of the major issues around suicidal teens in terms of health, seeking health care and asking for help is that, as we discussed, when you have suicidal thoughts, you tend to be more depressed, you tend to stay home, you might not ask for help. And we know that asking about suicidality in this age group is really important, and how we ask it is also very important, which Angela will talk about in a little bit. It's very important to have a systematic way of asking for suicidality in this population. We know that asking it through a computerized approach versus out loud is important. And we also know that it's very important for us to ask these questions without their parents around. Next slide. I think you all probably already know that it's super important that we screen for suicide risk in emergency departments. It is the only place that is open 24/7 for our teens that often are approaching the emergency department in crisis. We've had a quadrupling of self-harm visits in the past 20 years. And many of the things that are associated with elevated suicide risks are things that we see in teens that present to the emergency department: overdose, substance abuse, depression, and many types of self-inflicted injuries. And in fact, what we know is that 19% of children ages 12 through 17 had at least one ED visit in the past year. Next slide. This is just an example of the Joint Commission and the Sentinel event alert that they put out a few years ago, saying that we really have to detect and treat suicidal ideation in all of the settings: ambulatory, emergency department, and inpatient. Next slide, please. So there are a few things to think about when we screen for any problem in medicine. And one, we want to really make sure that we are satisfying like the 4 conditions of screening. First of all, we want to make sure that we're screening for something that's important and that there's a significant risk in our population. So meaning we don't want it to be something that's so rare that you aren't likely to have any case finding in that area. We want to screen for something that if you screen early, that we can make a difference in the trajectory of the outcome and that it's treatable. And so we know that suicide screening meets all of these criteria. And so it's really important that we screen in all of the settings where these teens present. And then we also know that it's important that we use effective tools. And in our setting, it's incredibly important that these tools are brief, that they're super easy to use, and obviously that they have good test characteristics. So different tools that we use for suicide screening might be better at casting a very wide net, meaning we're going to get many more potential kids with suicidal risk, but we might also get some false positives versus having a much deeper net where we only get kids who are at very high risk for suicidality, and we might have some false negatives. So we might miss some of the kids who are actually at risk. And depending on where you have your population, for example, if you're in a rural setting and you have very limited resources, it might be important for you to be more specific in your screening. Whereas if you're in a children's hospital with a lot of resources, you might be able to cast a wider net and therefore have a higher sensitivity. So it will be very, very important that that as you're thinking about how you're implementing screening in your site, that you understand what your site can tolerate in terms of dealing with those positive screens. Next slide. We also have heard from many that people are worried that if a child comes into the emergency department, a teen with a problem that's not related to suicidality or a mental health problem, why are we screening them for suicidality? Well, and parents are really concerned our nurses or other team members have been concerned that this might be something that isn't acceptable for families. But as it turns out, most people are very strongly agree that screening should be part of routine care in the emergency department, and that there might not be another place for them to be asked these questions. And so they're overall quite appreciative of being asked these questions. Next slide. I'm going to hand it over to Angela.
Thank you. I think you set this up well, because now that you guys are thinking about, okay, so we all know that we're probably on board with screening, but what kind of screening? So our recommendation is for universal, but I wanted to outline the difference between universal and selective screening. A lot of places already have selective screening in place. And so that's where you only screen those who are identified as high risk. So it might be that you have kind of a list of criteria. Everyone on your team knows if someone is using substances, has been part of interpersonal violence or maltreatment, presents with suicidal ideation or any mental health diagnosis, then they get the screen. Versus universal screening. Universal screening says everyone 10 and up, no matter why they're there, gets a screening, with some caveats, but in general, everyone is asked. The positive thing about universal screening is it's objective. So everyone gets a screening, right? It's not based on the clinician judgment. It's not based on waiting for someone to identify a high risk. We all know, Jackie already outlined all that. Kids are not going to tell us a lot of times. Oftentimes, there are signs, there's reasons why they're coming to the emergency department, and they're not telling us the whole truth in triage. Maybe it's scary, it's maybe not confidential. So everyone's getting asked the questions. And then it's also we all know that there's bias in healthcare. We all have it. It's hard to not carry it with us. And so no one knows what a suicidal kid looks like until they identify that they're suicidal. No one knows, there's no way to really tell. And so if we allow our bias to say, oh, I don't think that kid would be, I don't want to offend them, I don't want to ask. But that's your own self talking to yourself, when really that might have been the kid that needed to be asked. And then also, as we're talking about quality, it allows you to be able to look at what are our outcomes. Are we actually screening? Are we meeting the patients? Are we making an impact? Versus if it's case by case basis, it's hard to tell, are we screening the appropriate kids? Is this a really good sample of what's happening? What's the quality of our screening? It's really hard to tell because you don't know what kids to select from your population. And there's a lot of research out there to show how hard it is to pull that data, because there's so many different presenting problems that someone might put in. or to kind of to collect what that might look like. Okay, so next. So with universal screening, Jackie kind of already talked about this a little bit, but just to reiterate, it's the primary access point for a lot of our vulnerable youth. And so we know that primary care, sometimes it's difficult to get in with primary care, or that emergency departments oftentimes are the primary care. So there may not be another place where these kids are being screened. And the big thing that I talk about a lot is a lot of times high-risk kids need to know that you care. They need to know that when you ask, you really are going to do something with it, and that you'll follow up. And they feel that connection. So maybe they're not going to answer it today, but maybe next time they come in, if it's a kid who comes in often, they're going to tell you, or maybe they'll tell the doctor in the back versus, telling in triage. Asking in a way that conveys that you care and that their well-being means something to you, regardless if it's a hurt finger or if it's they're suicidal. That will come across if it's authentic and you feel comfortable in what you're doing, and then that will actually help more children. And then we also know it's an effective way to detect suicide risk among those present with ideation. So when there has been on universal versus selective, there's a lot of different research. One specifically, one that I like to quote is from Johns Hopkins, where almost 50% of the kids that they were identifying as having some level of risk did not present initially, identifying that they're there for mental health needs. Now, I think that that we do get a lot of mental health kids coming through the emergency departments now, but I do believe that they have different ways of presenting the stomach aches, headaches, chronic, different needs, and asking directly is the best way instead of trying to figure it out. Okay, next. And I just wanted to stop and pause again and talk about the bias that we have. We know that there are certain populations that are going up in the number of deaths and suicidal behavior. And oftentimes they might be not the stereotypical kid that you're thinking of. So knowing that the bias, so the stereotypical kid, everyone might have a stereotypical kid in their head of who is the suicidal kid. It may not be, as Jackie was pointing out, the athlete, the kid who goes to school every day, the kid who looks like your kid, or the kid who comes in and doesn't want to talk to you and just looks really angry. All of those kids could be suicidal. And I think that oftentimes we, when we're presented with that, we all have to approach every kid the same way, in the way that, in that way of, I really authentically want to know, and we can help you. So just wanted to pause and identify that again. Okay, so next. I don't have the fun slides. So my next one is, now that you're going to do screening, what are all the things that you have to think about? So this is kind of the operations side. So we're going to spend a little bit of time, the where, what, who, how screening. So next. So some things to consider. So if you do not have a universal screening in place, these are some of the things that when I've implemented it in different agencies, what some of the hiccups are. Ultimately, mapping out a pathway is what's needed. And so the first thing, as Jackie had mentioned, is making sure that it's confidential and the kid feels comfortable. So one question that often emergency departments have is, should I do it in triage or should I do it once a child is roomed or brought back? Oh, it looks like I'm breaking up a little bit. Hopefully things are better. But I think that the main thing is making sure that it's a confidential space. And so if you do, if you have not a confidential space, then you wait until they go to the room, making sure that you are mitigating any risks that are at having kids in the waiting room. So making sure that that you're identifying what some of those risks might be, and that you have a process for that. And then so one of the big things about screening is making sure that kids feel comfortable and it's confidential, right? So I always have been trained that if you were to go in front of a jury of 8th graders and you told them that you did a suicide risk screening with their mom in the room, they would probably be like, well, duh, they didn't tell you because the mom was in the room. So kind of put yourself in their shoes. So again, it might seem messy for your team and it might feel uncomfortable to ask a parent to step out of the room. But Jackie's already told you, most parents say, yes, if my kid was suicidal, I want you to ask. I would rather know, it's not going to harm them. And so ask about training your staff, making sure they feel comfortable with a place to step out. So stepping out to the other side of a curtain, not confidential. Everybody knows that. So kind of figuring out, what does that look like? If you don't have if there's not a good solution, are you going to use a paper or a tablet? I think a lot of EMRs will connect to a tablet and having them fill it out. As Jackie said, that is really a great way. Kids will tell you things via text, via tablet, more than verbally. A lot of times it's a lot easier. But if it's not connected to your EMR, what's that process going to look like? Is it too clunky? Is there risk that it's not going to get in the EMR? And who would score that? Okay, next. So getting to the who would score that? And then how is the screening entered into the EMR? Am I asking in triage? Is it part of the triage screen? Is it part of the physician intake? Is it scanned in? What does that look like? And is that really going to be a safe process that is reliable? Who's responsible for screening? So if no one's responsible, if everyone's responsible, nobody's responsible. So making sure that we know who is responsible for doing it. So if the triage nurse can't do it, they're reporting back for whatever reason that it isn't completed to someone to make sure that it does get done. In building EMRs, a lot of times we've talked about hard stop. I don't know if all the EMRs have talked about it, but is there a hard stop when screening? When is that? Can they be discharged and be like, oh, I forgot to do the screening. They were really upset and they refused to answer my questions, or they were unconscious and I never got to do the screening. So what happens then? Is there a hard stop at the end of of that process? And then also identifying who doesn't get screened and having a process for that so people feel comfortable. I didn't screen them because they came in unconscious and they went to the ICU. That's okay. There has to be, if there is a hard stop, you have to also have in your EMR a place to say, this is why I didn't screen. And that it has to be feasible. So is for cognitive delay, oftentimes you're not going to screen the same way that you would for a kid who is of typical development. And then finally, around this is, how do you ensure training and fidelity to the screening process? So if I'm going to say my nursing staff in general are in charge of the screening, either triage nurse or bedside nurse, how are we going to make sure that they all get trained and that they actually know what they're doing? So it's one thing to read something and sign off, say, yep, I read it. Do they actually feel comfortable doing it? Has anyone seen them? Do they know why they're doing it? So is there a process? So we've seen many different ways to do this. There's online modules, there's, bedside at the elbow kind of monitoring, there's skills, sim labs, whatever it is that you identify, but making sure that they have the tools that they need to actually be successful in this, because that's what's going to help the kids. Next. And then this one is all pretty much the same thing. I want to make sure that we get to the rest of the presentation and give you guys time for questions. So I think that's the main thing is the comfort level and what happens. So does everybody know? So yes, now they've screened, medium risk or moderate risk or high risk. What do I do next? How do I initiate that? Can a nurse initiate that? Does it have to have physician orders? What do I tell the family now? How do I explain what we're doing and what the next steps might? And then if I don't know, I'm a traveler, if I'm not familiar, where do I find it? Where can someone tell me I can easily find it so it doesn't slow down my process and that kids are getting care in a way that's efficient and effective? Next. All right, I will hand it back to Jackie for more fun.
Thank you, Angela. One of the things that I wanted to underscore with some of the points that Angela made is that this is a real process. So for those of you who are in the early stages of implementing suicide screening, it's uncomfortable for your teams. And I have had the honor of implementing suicide screening in a number of different emergency departments in the last 10 years. And what I found is that there is sort of a critical mass that happens as you start to screen these families, and people get more and more comfortable with it. And actually it becomes a mission for the people who are screening for the suicide screening. So for those of you who are just getting started, it can seem like a big undertaking, but it's really pretty empowering how quickly people take ownership of this screening and feel very mission driven in terms of being able to do this. So just kind of a little pro tip as you're starting to implement screening in your settings. So there are a number of screening instruments that you can use. The EIC has a nice link that gives you a number of different approaches for screening. One that's very well known is the Ask Suicide Questions, which is not the ask that primary care practitioners use for their for kids with developmental issues. But this one is really nice. It's basically a 4-question screen, and you can see the questions in front of you. These are sort of the biggies in terms of trying to uncover suicide risk. Notice that this particular ASQ it has also a no response option. Many of them are just yes or no. The no response option, by the way, is a really nice, important option if you want to increase the sensitivity of your screen of the ASQ. It casts a little bit of a wider net because people who respond, who put no response instead of no, are interestingly quite intermediate between the positive and the negative group. So they are really kids at pretty significant risk for suicidality, not as high as an overt positive, but not as low as a complete negative. And then we often in emergency medicine are really, we think it's really important to know how acute the situation is. So people add a 5th question for the ASQ, which is, have you had suicidal thoughts or had made an attempt in the last, have you had an attempt in the last 24 hours? Because that really changes how we treat them in the emergency department in terms of making sure that we get them roomed quickly, that we get a sitter and that type of thing. So ASQ is one example. The CSSRS is another example. I just completed the validation study for the computerized adaptive screen for suicidal youth through the PCARN network, which is a computerized adaptive screen that helps us actually, at the end of the screen, we get a point estimate for how likely an adolescent might be to have a suicide attempt at 3 months. So that's a really interesting approach for screening, because then you get not just a positive versus a negative, but you actually get, you have a 20% likelihood of a suicide attempt in 3 months. So that can help you in terms of determining how at risk your youth might be. So many different types of screening instruments, and you can choose what works best for your team. But as I said, making sure that it's brief and easy to use is really important. Embedding them in your medical record, if you can, makes it easiest. And having the ability for teens to fill it out on a tablet is wonderful, but that's not every place is able to do that. Next slide, please. And then you saw this before. This is a very complicated looking risk screening pathway. What happens once they screen positive? Are they acute positive, meaning they're at the highest risk for suicidality? Are they subacute, kind of non-acute, meaning they have had thoughts, but it was a while ago and it wasn't they weren't interrupting their thoughts, and it was sort of worrisome, but not incredibly worrisome, versus not having any suicidal thoughts at all. And depending on how acute you are, you're going to do different things. You could go to the next slide. This is the suicide screening pathway that we developed for the CASI, which is very similar to the screening pathways that you've seen using the Ask Suicide Questions or the CSSRS or other screens where you try to figure out what you do when you have a positive. And basically what is really important to think about is that we segment populations when they come into an emergency department. You're either, you come in with a mental health problem, in which case you're probably going to get a fairly significant mental health evaluation, we hope, although there's emerging evidence that, especially in our rural communities, even if you come in with a mental health diagnosis, you may not get a mental health evaluation. And so thinking about like kids who come in who have a mental health problem they're going to get a suicide screen most likely anyway. And then you can also segment for the non-suicidal kid and the non-mental health kids. And those are two different groups, and you can treat them sort of differently in terms of how much you're going to do with each group. For example, the kids who come in with a mental health evaluation, mental health problem, they're going to get an evaluation. Your social worker or your mental health professional can do the suicide screen and have a good plan for them if they are not very severely suicidal versus making sure that we are thinking about getting more significant help if they are suicidal. And then similarly, if you're in the medical presentation, a kid who comes in with a non-mental health presentation to the emergency department, those kids are different. The vast majority of those kids tend to be lower risk, but we do have a number of kids who are moderate risk, and we might want to make sure that we are now doing more of an assessment around, like, is there a gun in the house? What are the triggers? What kind of follow-up help do they have in place? Versus the highest risk kids, where you would absolutely make sure that you're doing a mental health assessment. So many different ways to approach these kids, but there are nice algorithms to help you deal with the positives when they happen. Next slide. And finally, this very busy slide is the example of the BSSA, which is the Brief Suicide Safety Assessment that Lisa Horowitz and the NIMH group put together. For physicians and others who might not have access to a mental health professional, and what are the things that we can do to assess these kids. So if you're in settings where it's very challenging to get mental health assessors or mental health professionals, you all can learn, many of you can learn how to do the Brief Suicide Safety Assessment, and you can feel confident that you can come up with understanding how at risk these kids are and who might be safe to send home versus having to send to a center that might be able to deal with these kids that are at the highest risk. Next slide, please. So this is just for those of you who want to look at, this is a nice toolkit at the NIMH, but again, the EIC has a lot of different great references for you all to be able to access for implementing your suicide screening. And then the next slide. So, overall, there's a few things that we want you to go home with in terms of take-home points. One thing is suicide screening is safe. Asking suicide screening questions will not introduce suicidal thoughts into your teens. That it's really important to have a validated screening tool as an emergency department, that you should have a very clear process on how you're going to do that screening. That depending on where you are, and even within your own ED, different diverse populations, you might have to have a different approach for different populations in terms of how to help them. That it's really important to think about doing universal screening for all kids over the age of 10, all youth over the age of 10, not to do focused risk-based screening. That it's really important to train staff to improve and how they do suicide care and how to test their competence in that. And that there are different approaches depending on how the resources are for your group. You might choose to have a wider net and be able to have more positives versus and some false positives versus having to have more specificity. And always, it's really important that we do no harm and that we take a patient-centered, trauma-informed approach to our screening. Next slide, please. So here are some of the resources that you all have access to. And if you're able to look at the toolkits that are available, you'll see lots of different approaches that might work for your settings. Next slide. All right, so I'm going to hand it back over to Jen, and we are going to have a question and answer session.
Yeah, thank you so much, guys. I think something that really struck me is that there is a lot of flexibility in implementing suicide screening for your site in terms of format and who asks and how it's embedded in the EMR. I'm not seeing any questions come up yet in the chat, so feel free to type them in, but I'll start with one, which is that we all know there's been so much mental health boarding going on. I could imagine sites that are thinking about implementing this are worried that identifying more positive children might impact ED flow in some way. Can you speak to that? And is there any data or any experiences that you've had on whether this impacts ED flow?
That's a really good, I'll start, and Angela, you can absolutely add on. It's a great question. You know, we do know that especially many of us just lived through the triple pandemic, where we had we had COVID, we had RSV, and we had the boarding crisis related to mental health boarding. And so it is a major issue. And I do understand the challenges of asking people to even have more risk to uncover, and then potentially having increased boarding in the ED. One thing I will say is that the good news is the vast majority of teens that we screen are likely to be not high risk, to be more likely non-acute positives, which can be dealt with relatively quickly. And most people are not needing to be admitted for the suicidality, but they might need a mental health evaluation. So it does increase the potential load of mental health assessment that is needed. But on the other hand, we are potentially intervening on a trajectory where these kids could have a suicide attempt or even a completion in the next 3 months, 3 to 6 months after the ED visit. So this is in terms of risk, and we don't have a lot of risk in pediatrics. I mean, when you think about febrile infants or you think about other issues, overall, our risk is pretty small compared to the adult population in terms of real morbidity and mortality, but suicidality is a major problem, and it does have more than a small attributable risk for poor outcomes. So really important to intervene early, and we can only do that by screening. Angela, any thoughts with that?
I was going to say very similar. I know that that has been an exact concern of multiple places that I've been. And I think that the main answer is the more that you know, and the more you're screening, you're talking, the more you understand that just because a kid says that they've had suicidal thoughts doesn't mean they have to board, right? So there's all these processes, and you're doing the upstream approach. So we know that we're living in a crisis-driven mental health system right now. And so any way that we can start identifying kids who are at risk ahead of time, as Jackie said, we're not necessarily talking about, having to get a sitter and having a full-blown process for some of these kids, identifying that they just are struggling and they need help. There's an easy process for that oftentimes, and you just have to hardwire that into your program. And so as Jackie said, like, you'll get champions, you'll get people who are like, yes, I get this, and it will become more comfortable.
Yeah, that's great. At my hospital, after we implemented universal suicide screening, within a month, we had a teenager who came in for a broken arm and was found to have suicide thoughts and a plan. And I really think that we probably saved his life. And for the most part, among adolescents visiting our ED, they're more likely to die by suicide than by the reason that they came in for. It looks like there is a question in the chat around how do you handle parents that refuse to leave the room or become angry over screening? And I'll broaden that a little bit and ask maybe Angela, is there a certain script that you use to ask parents to leave the room that you recommend? How do you recommend that we word that? And then also, should we give any opening statements to the adolescents before we jump into the questions around confidentiality?
Oh, there's many different ways you can. It depends on what your normal script is, but oftentimes, I mean, the script is just basically, and now that you're a teenager, there's some questions that we like to ask without your parents in the room. Parents, I can tell you what those are when we're done, but I just need you to step out of the room because I know they're more likely, it's easier to talk to me without the parents in the room. And if there's any issues, because we talk about confidentiality at the time, if there's any issues where I think that you're at great risk or there's anything, then we'll talk about, happy to talk to the parents. We'll have that conversation. And so in general, I have never had a parent refuse to leave the room. They might be like, oh, maybe, but it's how you present it. So it's like, okay, this is our standard procedure. I just need you to step around the corner and go sit down. I'll come and grab you when we're done. They might want to know a little bit more than what I want to tell them afterwards, but in general, like having that upfront conversation, letting the kid know, here's why we're having this conversation. And ultimately, I think with the ask script, it also starts with that just honest answer of, we care about the safety and the whole wellness of the child. And so we're going to ask some questions that are confidential. And we know that children are more likely to answer honestly when their parents aren't in the room. I don't think there's anything private, and there's nothing secretive about that. Jackie, I don't know if you've got different experience.
Oh, no, I love how you said to the parents, this is part of our daily, this is how we ask questions of our adolescents, and every parent leaves the room, and it's just standard. It's how we do things. And sometimes you do get parents that balk at that, but overall, I have to say, with just some gentle persuasion, you're able to have families leave the room. Now, having said that, I have had a few families angry at the fact that there was a positive suicide screen, especially in a kid who came in with an ankle injury. And I will give you one very interesting case. It was very similar to what Jen was talking about. A mother was extremely upset because a kid had acute risk, had actually had suicidal thoughts, and had a plan, ended up having to be evaluated, and was able at the end of the day to go home, but it did take some time. The family was super upset. This was early on in screening, setting up our screening at my previous institution, and probably early on in terms of universal screening across the country. So maybe our team wasn't all 100% into doing this either, because it was causing, it was more work. It was uncomfortable. We had to deal with it every now and then. But I will tell you, this family was really upset that we had screened this kid. And sometimes, for the years that I've done this, when a family is really, really upset, that's kind of the smoke where I know there's a fire. And so that makes me even more, I think it's even more important to help those families kind of through this. And it's like the stages of change almost about some people are pre-contemplative. Some people are more in the contemplative mode once they hear about these things. And so sometimes we've got to get families from that pre-contemplation into contemplation, and then hopefully into doing something action oriented. And this family that caused this mother, who was really upset, called me about 5 days later because my name was on the chart, and she told me how much she appreciated that we had screened her child for suicidality, that she had been worried, and that she apologized for being so upset, and that she had already made, had been able to get an appointment for her child to be evaluated. So again, families are at different points along the sort of contemplation, pre-contemplation spectrum, but sometimes they can be angry, and that's okay. And we kind of have to be a little comfortable with that as well.
Great. Yeah, I would say that's definitely the rare circumstance for sure, but important to know how to handle it when it happens. Question for Angela. You mentioned briefly potentially taking a different approach to children with developmental delay or cognitive impairment. Can you speak to that a little bit? How do you handle that when kids have some developmental delay?
So it depends on the range, because there could be many. And there's a lot of researchers trainings out there for assessing kids with developmental delay, as well as adults with developmental delay. And a lot of times it's asking the more questions closer to, have you ever had thoughts of not wanting to wake up, or, you can still ask about suicide, but they may not know what that is, right? So I think kind of asking that also might be a time when you talk to parents or caregivers and ask about any behavior changes. You have on those, it's a little bit more of putting together the pieces, depending on what level of delay they're having. So kids with IDD or developmental delays, can have suicidal ideation, for sure. It may look different and they might express it differently. But I think identifying words they might be like, I don't want to be here, or wish I wouldn't wake up, or asking different questions. But we kind of on there of understanding, sometimes asking parents, but kind of treating them like a little bit of younger age. So I think that's kind of the answer. I think every screening tool has their own that's what I'm kind of like stumbling along, because every screening tool has their own recommendation. So like the CSSRS has a child version that you would use. And so you would use those also for kids that have IDD. And so CAMS has kind of a way that you think about things, and everyone has a little different way of the way that you ask the questions. But I think, so I was trying to get to like the mindset that you have of coming in, of like knowing that they may not outwardly say that, but there might be things that they're doing that they believe might harm themselves, and they're doing that intentionally, just the same way that a younger child might do.
Sure. And a follow-up question for Jackie. Why was age 10 chosen for universal screening? Is it important to be screening those preteens? And then what kinds of rates should places expect to achieve in a feasible manner? I mean, no one can get to exactly 100%. What kinds of rates are actually possible out there?
Oh, great. So for your first question, it seems shocking that we have to screen for kids that are 10 years old. And I tell you, that is probably the thing I hear from parents most of all, is that's their they might not be uncomfortable with their 14-year-olds, but they might be a little more uncomfortable for the 10-year-olds. But here's the deal. That age group has had one of the most significant increases in suicidality for reasons that are not entirely clear over the last 4 to 5 years. So we know that this is an important age group. There's more than just trivial suicidality in that age group. And that's when the inflection starts to increase for that. So unfortunately, we do have to ask we have to ask for suicidality. And sadly, there's even younger kids who have had who are suicidal. And that's an even more perplexing issue. Again, we're getting at, as you get younger, the way that you ask for the way that you screen for suicidality is very different, as Angela described. But most of the tools that we use we are able to use them in 10 and up. So it's in terms of being effective and validated, it's reasonable, but it is really heartbreaking to think that we need to screen in that young of an age group, but very important to do. The second question was around what kind of, how successful can we be with respect to our screening? And the answer is, I like to think aspirationally, which you can see that the one of the benchmarks we think about, like what would be acceptable to you. I say 100%, but I know that's aspirational. The answer is that we're above 90% at all of the places that I've introduced screening within 6 months, 8 months are at the 90% mark for screening, for all universal screening in kids that are able to answer the question. So the proviso is that it is true that if a kid comes in with severe pain and it got morphine because they were feeling really sick, at that moment, they might not be able to be screened, but we go back and then try to screen for those. We make sure that we're able to screen once they are more cognitively with it. Obviously, if there's head trauma, and they're not able to, they have a Glasgow coma scale of less than 13, or they're really not with it, those aren't kids that we would screen. But overall, we're able to screen the vast majority of teenagers that come into the emergency department, even if they have some pain, or if they have a migraine headache and they're getting the migraine cocktail, we're able to screen those kids for suicidality. So I'd say if you could get above 90%, personally, that is what I've seen in many institutions, that is doable. once your workforce, and it's usually nurses, unfortunately, that tend to be, thank God for our nurses. They do a lot of the screening as they're doing intake for these families. Once these amazing team members are on board, we are able to have about 90% or above. And I'd love to hear from Angela and Jen to see what your experience has been.
I would say the same thing. I would say that once everyone has a comfort level and knows and kind of makes it part of the routine, everybody routinely gets screened. I mean, even knows to look and like knows like, okay, this is a kid that maybe wasn't screened, even if you don't have the hard stop, we'll go back and make sure that that's been checked before they go home. We haven't.
Yeah, speaking to comfort, are there any specific training resources that you recommend?
I will say, there's a lot. I mean, there's lots of YouTube videos to watch. There's lots of different trainers or trainees that you can do. All of the regardless of which tool that you decide, I've found that all of the makers of the tools are very accessible. And so you can say, what would you recommend? TJC has some trainings. So I think there's all of those. I think kind of having resources, there's 2 steps of identifying the tool that's going to work for you, for your hospital, that is going to be able to be implemented and used easily is one thing. And then the next one is, how do you train? And I think that's really what you were asking. And I think that is getting a core group of people who are champions and really training and feeling comfortable to be able to give feedback to others and listening. And so I found that people really can do the modules, but then when they have to put it in practice and they haven't said it out loud, it seems weird and awkward. And so having either if nurses are doing it, because nurses do it most of the time, like a skills lab or a Sims, they're having to do that in pairs. Not a role play, but that's really the most effective. Having people at bedside, at the elbow, helping. So when someone comes through, that they're able to be there and problem solve and talk through, because once you do it, then you feel more comfortable and you can help others.
Yeah, Angela, I would say that's exactly my experience, is that it's there's this sort of the lab learning that you do. You do your module, and then you do the role play, and you sit and you say it out loud, and you kind of get comfortable saying the words out loud, and then you work with somebody who's comfortable, who can say you're doing a good job and go for it, and and go ahead and ask your questions. And just, it's really important for for people who are screening to understand what it feels like, that there is anxiety initially. And the first few times you uncover risk, and then you have to go back to talk to the families, it is, the first few times feel a little anxiety producing, but the good news is that that's a fairly brief period of time, and you do it a few times and you get much more comfortable with it. Again, practice makes perfect.
Thank you both so much for all of your practical tips today. We've really appreciated having you and the wealth of expertise that you shared with everyone. I am going to wrap things up and turn it back to Laura for some closing remarks.
Thank you all. That was a very fascinating and informative talk, and I really appreciate everything you did to make it happen today. So there was a link put into the chat that goes to our webpage that has the list of the fireside chats that are coming up, as well as the collaborative sessions. And we hope you will go there and pre-register for these events and attend. With that, please look for follow-up emails, and thank you to everyone, and have a good day.